Okay, so how do you assess a psychiatric patient? How do you conduct an assessment? And you've learned about history taking in general medicine. Some slight differences in psychiatry. So, quite obviously, some of the goals are to return a diagnosis or formulation, understand the context of the diagnosis, and to establish a therapeutic relationship. Very important if you're going, if the patient's going to remain under your care. So, why it's important to make a diagnosis? So, diagnosis is really central to the practice of psychiatry. Well, I should say diagnosis stroke formulation, and we touched upon the importance of this in the classification lecture. So, it provides a rationale. Well, it's really a start to evidence-based treatment and prognosis. Important to consider differential diagnoses in psychiatry. It's not always possible to make a definite diagnosis, and really we should be wary of jumping too quickly into a diagnosis. So, not uncommonly, we would offer a working diagnosis, and then over the next few days or weeks, as you have more contact with the patient, as you get more information, then you can be more confident about your diagnosis. It is important to have information about the patient's life history, current circumstances, and personality. So, very often we are dealing with chronic disorders, and a very important question to ask and to seek the answer to is why has this happened to this person at this time in their life, and that may be a mix of many factors. Important not to miss out on the social factors. It's very difficult to make progress with a patient if you are unable to develop a relationship whereby the patient has confidence in you, because you're really asking them to open up their inner selves to you, and if the patient has confidence in you, they're more likely to go along with your suggested treatment. So, how do you start? Very important to look at background information. So, before I will see a patient, I will have a look at their previous notes, their previous assessments, their previous admissions. However, it's important to be open-minded about previous and past diagnoses. If you don't think something fits, as a doctor, you should have the confidence to challenge a previous diagnosis. Okay. So, what do you like to be called is a very important start to make the patient feel comfortable. Start slowly. Go gently, and you really have to leave the more sensitive questions until you've established some rapport. And I'm very keen on just chatting to patients, just to start with, just a starter to and fro of conversation. So leave sensitive questions till later. You may be familiar with some of these headings of a psychiatric history, and what you'll notice here is that I would recommend leaving the presenting complaint and the history of presenting complaint until the end of your interview. So you can't have as your leading question, so tell me about your overdose last night, or so tell me about your attempted hanging last night. These are some things that you need to work up to. So very importantly, start off with demographics. So name, age, where do you live, who do you live with, are you married, are you single, do you have children, do you have young children living at home, are you working, what are you on benefits, on which ones. Then in the spirit of starting off with less sensitive questions, I usually then take a medication history. This also gives you some clues about previous diagnoses. So what medication is he taking, what and why, and importantly you've got to leave room for the patient to tell you that they're not actually taking them. Don't just assume that because it's prescribed the patient is taking them. So I will usually say, so this sertraline you're prescribed, do you take it every day, some days, or just when you need it? And you'll be surprised at that. And then ask about benefits and side effects. So again, typically with antidepressants, I will say, so you've been taking this for 3 months. Has it made you feel better, worse, or no different? And again, you will often be surprised at the answers. So here's some typical medication history. This particular patient said that he only takes the citalopram occasionally, and when he's feeling really bad, he will take 2 tablets, which is not how it's prescribed. And generally, he finds that it's not been of any benefit, and it makes him feel sick. So past medical history, I think you're more familiar with. So past psychiatric history, any previous contact with mental health services. Have you ever seen a psychiatrist before? Have you ever been admitted to a psychiatric hospital? And in this fictional case, this man had taken a previous low intent overdose of medication and had one previous admission, an informal admission. He'd never been detained. So family history, ask about parents, siblings, and the wider family. This is, we take a family history really to get at the genetics of mental disorders, and this is hugely important. I would say that all virtually all mental disorders have a very strong genetic basis, and if you look at bipolar disorder and schizophrenia, heritability rates of over 85%. So family history is really about the genetics. It's also about relationships, as well. Then personal history. This is really going from year 0 and until now. Ask about their childhood and schooling. I must admit, I can't remember the last time I asked anybody whether they had had a normal vaginal delivery. I think I did that when I was a student, and you just get very strange looks when you ask that question. So there are some situations when you might need to ask it, but childhood, schooling, work, and family. You must ask about alcohol and drugs. I mean, all of the literature shows that the doctors and psychiatrists are very poor at taking drug and alcohol histories. I mean, I will ask every patient that I see how much they drink, whether they drink, and whether they take drugs. And important then, if you suspect that there is an issue with either alcohol or drugs, you take a longitudinal history, a history of current consumption, and a history of complications. So somebody's drinking, you might ask about liver complications. If someone's taking lots of ketamine, you might ask about bladder complications, for example. It's important to take a history and question someone about personality and temperament. Again, this is very much something that's overlooked in history taking. There are lots of personality inventories. The one that I use is the Big Five personality inventory, whereby someone's personality is graded according to these five criteria along a spectrum. So if you're not familiar with this, I would suggest you read up about it. Now, only after going through all of this background, I would suggest that you come back to talk about the presenting complaint and the history of presenting complaint, remembering that we very often deal with chronic illnesses. So the question is very often, why now? Why has this relapse happened? Why is somebody unwell now? And go through, the index event, for example, if it's, and ask detailed questions around an overdose or have an idea of why this relapse has started. Here we go, details of the index recent event. And you can use inventories, so particularly in deliberate self-harm, it's very useful to use an intent scale such as the Pierce suicide intent scale. If you're not familiar with that, then I'd suggest read up on that. Okay, so there are very few investigations in psychiatry. One that is invaluable is obtaining a collateral history, so speaking to someone's partner, their parents, their friends, or if I'm seeing a patient in A&E or on one of the wards, I will speak to the staff. I will want to know how that patient's been behaving in the last few days or the last few hours that they got there. So once you have completed a history, you will then proceed to conduct and document a mental state examination, perform an appropriate physical examination. You might want to do some investigations. A urine drug screen, for example, is quite common. Then you would record either a working diagnosis, differential diagnosis, your impression. Very important always to consider and document a risk assessment, and from there you can determine a plan which ideally you should fully discuss and agree with your patient. And later videos will cover some of these headings. Okay, any questions or comments, please post below.